So posteromedial ankle approaches. So first confession to make is that I'm not a foot and ankle surgeon. That's always a good confession to make, that I am a trauma surgeon and tend to do a fair number of pylons. And it's useful to have this in your repertoire, the posteromedial approach. But what's the problem with pylons? The problem with pylons is that their soft tissues are often terrible. And there's, you know, whether you go down the Edinburgh route of fixing them early or a staged process, that's entirely up to you. But all I would say is just be cautious of the soft tissues and manage your soft tissues as part of your management algorithm for dealing with the pylon. The other main issue with pylons, and I love this diagram, I got it from an old paper from the 1960s, I think, about the vascularity of the distal tibia. The other issue with the pylons is that how bad their vascularity is. And you can see this bare area. You can see this bare area here where we tend to put on our anterolateral plate. But look, all the blood supply tends to be coming from the soft tissues and it's medial. So those medial plates that we put on, there's another violation to that soft tissue and to the vascularity of the bone itself. And there's and also in addition to the trauma effect of the vascularity as well. So they can be pretty significant in terms of the damage and their progress onto non-union or soft tissue complications. There we go. There's been a fair amount of work about common fracture patterns, and now over time we're developing this column theory basis of pylon fractures, looking at really there being a medial column, an anterior column, and a posterior column, and the main fractures are variations of that effect. And often our focus is on getting this Voltman fragment down and reduced, but there's been some good stuff from a guy in Liverpool about how if you just get this down and haven't addressed the medial column, what happens is that putting the posterolateral part down pushes out the medial column. And so actually addressing the medial column first to get that back in its place, or getting some sort of hold on it, whether that's a clamp or a screw or a plate, helps with addressing the whole of the posterior part of the ankle for reducing its articular congruity. Quick synopsis of ankle approaches. I mean, there are loads of them, and just reading this morning about a few being published in the OTA about a trans Achilles tendon approach to the back of the ankle. I'm not sure I would fancy doing that, but you've got your lateral one, or the variation of the lateral, which takes you just lateral to peroneus tertius, your direct anterior, your anteromedial, your posterolateral, which we know about between the peroneals and FHL, and your posteromedial, which is quite interesting actually, because the posteromedial varies depending on what you're trying to get and where you're trying to get to. Typically it's based on the same incision. So typically proximally it's on your fasciotomy line, and it's a midpoint between tibialis anterior and the posterior medial part of the medial malleolus. And it's an approach that's centered around the neurovascular bundle that you're trying to find. And you know, Tom, Dick, and the very naughty Harry always comes to mind when I'm talking about these or doing these things. So what's my principles on the fracture side of things? Soft tissues are key to me, and two main complications that I'm trying to avoid when I'm fixing these is non-union and a soft tissue complication, such as infection that then leads to an infected non-union, etc. So if I'm using a 2-incision technique, one's going to be extensile, usually the posterior one if I'm honest, and one is minimally invasive, so really MIPO type, minimize my soft tissue insults. And I'm moving towards more of a column-based theory of practice. And which column am I addressing when I'm looking through that scan is dependent on where my easiest metaphyseal read is to try and get my articular congruity, and which one's the most short, right? So is it the posterolateral or is it the posteromedial? Which one's the most short column? And I'm targeting the incision. I'm targeting the incision as to where that fracture line is, where I can see that reduction. But where you see that reduction isn't exactly where you can get a plate onto. I mean, you can't get a plate directly on a fracture line, all your screws will be in a fracture hole. So it's thinking about targeting your incision to see the fracture line, but also to be able to apply the buttress effect or the push effect in an appropriate vector to reduce things. So why address the posterior medial column? We've got two sort of fractures here. It's minimally displaced, right? You don't really potentially need to reduce it. The problem is, though, if you look at where the fracture line is, it's coming here and it's really lending itself to a posteromedial approach. And there's a variation of the posteromedial approach that nicely lets you get on both a Voltman fragment and on a posteromedial fragment. And the idea, the theory is that if you have some of these fractures and you have to get this posterior or this medial column reduced, it allows you to get access to the back as well. And this is a thing to be aware of. You reduce this and it pushes off your posteromedial fracture line. So here are the considerations. Fracture line for visualization of the reduction. You're assessing your columns for fixation. Now, when you think about the ankles, often breaks in a spiral pattern, or the pylon breaks in a sort of a spiral component. And I used to think, well, you just have to capture the apex. You just have to push the apex back. But I think it's a bit more complicated than that. You have to capture the apex, but then you have to think about where the net vector of reduction may be. Because if you just capture the apex and it spirals in a different direction, you've only caught the apex. You've not created a net vector force to reduce the ankle to its center point, or reduce that fragment to the center point. I hope that's clearly explained. So in my mind now, there's kind of an evolution or a development of my thoughts that it's not just capture apex, it's think about where I'm trying to get the vector of push and how I'm going to try and reduce that so it all sits in nicely together. The posteromedial is quite cool because it's almost a 3-in-1, right? So you've got the proximal, at the proximal you've got the fasciotomy interval, so this is proximally here, and here's where the spike is, here's where I'm going to capture it, and obviously if I'm coming in at this angle, that doesn't really make sense, so it's almost in the fasciotomy plane. So you're between the tibial bone, 1.5 centimeters behind it, and the tibialis posterior tendon. And then in the middle, or sort of more towards the ankle, so middle, within 5 centimeters of the ankle, you're trying to view your fracture plane, but also secure your visualization, and that tends to be between this fella here, tibialis posterior, and flexor digitorum, and here we have FHL, and that's quite nice because you can use a tendon to protect your neurovascular bundle. And then when you end in the articular zone, you end up. There we go, we've got tibialis posterior, flexor digitorum, neurovascular bundle. You're working between neurovascular bundle and FHL. So you've got these three different things, 3 different parts of your approach and working different intervals. So for example, you work this interval to get your approach between neurovascular bundle and FHL, but actually to secure your screws, you might go between tibialis posterior and flexor digitorum. So the thing is, right, so when you're coming from a posterolateral and you strip off FHL, oh, here it is, and you strip off FHL, you're taking FHL medially. You're taking it to its knot of Henry. Yep, so that makes sense. But when you're coming through the posteromedial approach, you tend to take FHL laterally and everything gets really tight. Well, Alex Vrish showed me a really cool thing. So if you take FHL medially, even though you're doing a medial approach, you end up not only being able to see the posteromedial column, but you can see all of the posterolateral column. And this is what I did in this approach. And you can see this plate, that's way off posterolaterally, and that's applied through this posteromedial approach. Okay, so it's quite a good modification, or quite a nice modification, to take FHL medially, and then you can expose that. And that's just, I thought it was original thought by Alex, but I found a whole load of papers in the OTA that describe this modification of this technique. And it gives you like 90% exposure at the back of the ankle compared to 60 just through a posterolateral approach. I borrowed my wife for this. And some of the issues around pylon fracture fixations is not just thinking about where's your way in and how you're going to affect your fix. It's about thinking about positioning, right? If you're having to prone somebody, then supine somebody, that's quite a big deal. So there are whole loads of different ways. If you're dealing with an entirely posterior injury, then proning somebody is a good idea. But if you're dealing with somebody that's a posterior injury and an anterior injury, and your posterior fix can affect your anterior fix, then that can be quite complicated, and being prone doesn't always help. There's all sorts of different things. So here's when you put a sandbag under the hip on that side, and to externally rotate the patient a little bit, you get a better access just posteromedially. If you're just looking at posteromedial, or you can do bad leg down, but I can't really see the point of that because it's hard to do a combined approach. And this is my preferred approach for the posteromedial to even posterolateral approach. So using a posteromedial incision to get all the way across, and then I can take this sandbag out here, or borrow the cushion, and rotate the leg around. And I find this as my combined approach is the best thing. So here we go, 742, almost there. This is my strategy for pylons, and trust me, it's always under refinement. I'm thinking about where the fracture line is. I'm thinking, do I need one incision, or do I need two incision technique to a 2-column or 1-column? And if I'm using a 2-column type technique or a 2 incision technique, one is going to be extensile and one is going to be midpo, and I'm going to try and make them at opposite ends as far as I can of the ankle. So usually it's a direct anterior with either a variation of a posterolateral or posteromedial approach. This is something I learned from Matthew Kirkovich. Fixing the fibula helps to restore alignment. It helps to bring the Volkmann fragment down. So if I can think of my approach, I'm thinking, do I need to fix the fibula? And will fixing the fibula improve my, my overall alignment? The interesting thing is being able to get to the posterolateral column, the Volkmann fragment, through the posteromedial approach. That's been a revelation, and actually a really useful development in my practice. And I have a preference when it comes to positioning for a sloppy position in a figure of 4 type position with a sandbag just to roll the hip out. Great. I think, oh, I've got some cases, but I've 744. So I think that probably concludes our talk really for today. If anyone has any burning questions, feel free to ask. Thanks, Lee.
Thanks, Jay.
Hammered it, Jay. Hammered it.
Hammered it accurately or hammered it normally? I don't know.
Like a pylon.
Like a pylon. Hammered it like a pylon. I think it's natural progression onto the other approaches of the ankle. And we also did this in our pelvis to toe tip course, which was done very nicely as well. Sponsored by Striker, little plug.
Sai is asking for you to do one case. He's got time. Have you got time? Jay?
Yes. Yeah. Yeah, I've got time.
Sai's asked to go through one case. If you've got time, he's got time. Is that right, Sai?
Yeah, that'd be great if you could. It'd be nice just to bring it up there.
Do one case.
Of course. I've got 3 in preparation side, so we can do one. Here's one. So I don't have the answers because some of them end up in a disaster, and I think this guy ended up in a disaster. But what are you seeing here, friend?
So you've got your 4 fragments that you talked about earlier. You've got your medial, anterior, and posterior and lateral. And
yes,
you know, again, the combined approach is most likely going to be required to get this anatomically reduced and stabilized rigidly.
Yes.
And so I'd like to get more.
What's your ways in there? What are you thinking as your routes into this fracture? What's your approach? What's your positioning?
So you talked about the posteromedial approach, but here your fragments are more anterolateral and posterolateral. So I'm not sure really.
Yeah, nothing like a teaching session to add confusion, is there?
Yeah.
Well, okay, so the anterior bit is easy, isn't it? So what are you thinking here?
So you know, you can do your standard anterolateral approach and try and bring that down just between the anterior fibula and PT. And then the posterolateral, I think you would do a posterolateral approach to get that fragment.
Yeah, yeah. So in my head, I'm thinking this is probably the direct anterior right here between tib and the others. It's pretty good for getting this fracture visualization, right? It's also sort of a zone of injury. and may lend itself to even getting down here with a McDonald or something to reduce that depression. Yes?
Yeah.
I'm looking at this, and I got a confession to make, if this is the guy that I'm thinking about, is that I didn't get it right. Okay, I haven't got images of that, but I went in posterolateral to address the fibula, bring the Boltzmann down, but this fragment didn't take any screws because it was so fragile, and indeed there was a degree of displacement of the medial fragment because I pushed this in, and I pushed the posterolateral bit in, and it pushed out the posteromedial. Yes, so making actually the anterior reduction hard. So if I was to reconsider this in my head, I'd probably do a posteromedial because it looks like viewing it through here, this will give me a great read. With the natural tendency of the ankle, when you're prone, is for it to sit externally rotated, exposing the medial surface. Yes, it doesn't expose up the posterolateral surface, and because of the oblique orientation of the ankle, yeah. And when you're prone, so if we're thinking about this prone now side, and here's the fibula, if you're looking at me, I hope this makes sense. Here's the fibula. You tend to not see so much of the medial surface. So it's almost impossible beyond FHL to really see down here. Yeah? So then I'm looking at columns. Someone's got to mute themselves. You're looking at columns, and I'm thinking, where's my metaphyseal read? Yeah, and here's my metaphyseal read on the posterolateral column. So I think I'd agree with you. This is a good win here on the posterolateral aspect of it. There's also a metaphyseal read here. Okay, so I would say that there's probably more ways to want to skin a cat, but this would lend itself to a combined approach. Yeah, either posterolateral, posteromedial, or a direct anterior. So I don't think you're wrong in considering either. What do you think?
I think posteromedial and then doing the anterolateral sort of means you can do more like a 360 fixation, couldn't you? Rather than going posterolateral, anterolateral. From just looking at those coronal views, is that something? Because then you're buttressing from both ends around, essentially. Not buttressing, but fixing. Sorry.
Fixing. Yeah. So this guy did really well. In fact, he did really badly. So I did a posterolateral and a direct, and I didn't do a direct anterior because his soft tissues were so bad that I effectively only fixed one column, and then I did a Mippo perk fixation on the medial column to just hold it, and the alignment looks great. And then I think he jumped out of another building and destroyed his fixation. So I'm blaming him, not me. But it's entirely my fault for not. Well, it isn't. Is this still being recorded? It could have had a more solid fix if the soft tissues would have allowed it. Here's a cool one. This is the one earlier on. Side. What's this lend itself to? Anyone up for a green?
I would say too.
Yeah. Carry on.
A post approach for this one because it's, the fracture line is exiting more medially, and you talked about those three windows, didn't you? You'll probably need all of those three bits to your posteromedial approach.
That's right. That's right. Here, if we think about it, your view, and even on a prone patient, is like this, okay? And it's so hard to see this through a posterolateral approach. But if you come in here, my God, and you move this medially to the knot of Henry, if you move it medially, then you end up with an amazing view of this, and you can get everything down. And also you're avoiding that complication that you might get if you go through a posterolateral approach of coming through here and pushing this out of the way. So lends itself to a posteromedial approach. Yeah. And then it's your choice. Do you want to do, there's no issue at the front here, right? So we don't have to do a combined approach. It's purely a posterior pylon. Yes. So this can be done in a nice prone position because you know that you don't need a combined approach. Yep. Good. And so this is what we're talking about. You've got this depressed fragments come in. So in one interval coming more proximally, you can work between the tendons and work neurovascular bundle. And here the apex is on the fasciotomy plane. So lends itself to a posteromedial approach. And you can see it's very much a posterior pylon variant, isn't it? And that's the guy that I demonstrated earlier on for the approach. And he's doing okay. It's not brilliant. I've got some incongruity, you know, but I think it's pretty decent. Oh, thank you, everybody. Thanks for listening. I hope that was both entertaining and valuable. You'll be the judge of that. But here's to next time.
Thanks, Jay.
Oh, thanks, Lee. I'm just going to leave now.
Yeah, all good. Thank you.